Reflectance confocal microscopy can be used in clinic to improve diagnostic capabilities in dermatology. Everything from skin cancer to a parasite can be seen with this device. However, our group uses it mostly for pigmented skin lesions and lesions suspected of early melanomas. Pigmented lesions have melanin, and melanin can be seen with confocal microscopy as white or bright because it refracts at a near infrared wavelength. This way, we can look at melanocytes or different structures and better determine if their morphology or architecture is normal or atypical. Since the device only uses one signal, the images are in grayscale, more like an ultrasound. Additionally, we look at them horizontally, which is quite opposite of what we use in histopathology. This can make learning interpret confocal images a little bit challenging sometimes because the lack of color and the orientation is different of how we read histopathology. The cell seen here in our case is quite distinctive. It is a dendritic cell located high on the epidermis that is very bright and solitary. Activated Langerhans cells cannot be differentiated from dendritic melanocytes upon confocal because their morphology is quite similar. This is a very documented diagnostic pitfall, but in our case, given the clinical atypia and the patient's history of melanoma, we weren't sure if this was a Langerhans cell or a dendritic melanocyte. Once we got the biopsy results that were consistent with our inflamed nevus, we felt more confident that this was a Langerhans cell and not an atypical melanocyte. Confocal microscopy is used more and more in clinic, helping decision-making in real time. Although it cannot match histopathology as a gold standard, it can help reduce unnecessary biopsies or can help diagnose melanoma in its early stages.